Pointer, please. That the red area shows the areas where there's a high risk of ROP-related blindness, and you see that India is one among them. And it's basically because of improving neonatal care, we're saving smaller babies, but screening is not always adequate in these places. So typical of ROP in developing countries is that we see more severe cases, there's lack of awareness, there's lack of access to care, with referral reluctance among our colleagues, with late arrivals will lead to more and more of ROP blindness. So good ROP screening program is a cooperative effort between the ophthalmologist and the neonatologist. It helps to identify babies at risk, ensures timely detection, prompt treatment and referral, and avoids unfavorable outcomes. So the American guidelines, if you see, they say that we should screen babies less than 1500 grams birth weight, less than 30-week gestation age or higher, in case of high-risk babies. And they say that we should screen babies 31 weeks post-conceptional age or 4 weeks, whichever is later. However, the Indian scenario is a little different because we see babies with smaller babies with ROP as well, and larger babies with ROP as well, because of improved survival and because of poor neonatal practices. So if you see the global gestation age data, we see that on the left side, there are countries like UK and USA which have much smaller babies developing ROP, and in more developing countries, bigger babies are developing ROP. India is marked by the blue arrow. So one guideline cannot be applicable to the entire world. Similarly, if you see the birth weight data, global gestation data, you see that again the developed countries like UK, USA have much smaller babies developing ROP, while as we go more towards the developing countries side, the bigger babies are developing ROP. So the guidelines have to change, and they cannot be applicable throughout the world, the similar guidelines. So here we basically now follow the National Neonatology Forum guidelines, which is the PEC's body for neonatologists in India, and what they have decided that which babies should you screen. So these are the current guidelines: 750 gram birth weight and or less than 34 weeks gestation age baby should be screened for ROP. However, if they have risk factors for ROP, then you can screen babies till 2 kg and 36 weeks as well. So when should you screen these babies? Again, they say that if the baby is equal to or greater than 28 weeks, then you should not screen later than 4 weeks, or the first screening should be done within 30 days of life. However, if the baby is smaller, less than 28 weeks or less than 1200 grams, then early screening for 2 to 3 weeks is recommended, because to pick up cases like APROP. Where should you screen? Preferably you should screen in the neonatal ICU, where it's easy for the neonatologist to coordinate all the ROP activities, monitor systemic status of the baby, and combine it with routine neonatal visits. It's very important to explain to the parents what you're going to do. They should know what is ROP. They have to know that the child may deteriorate. They have to know that a large percent of ROP might regress spontaneously as well, and they also need to know the importance of regular follow-up. Informed consent is very essential, because you might end up with medical legal issues. The baby should be warm, dry, and fed, and only safety precautions should be taken to examine these babies. Pupillary dilation is a very important component of examination of his eyes, and you should use a concentration of 2.5% phenylephrine and 0.5% tropicamide combination. Now this is different from the regular adult combination almost by half, so you need to dilute these drugs, or you can have a pharmacy prepare it for you, and these can be used to dilate these babies. The full strength should not be used to dilate these babies for risk of systemic absorption and side effects. You need to examine the anterior segment, and basically what you're trying to look for is a corneal clarity, a tunica vasculosa lentis, see how the pupillary dilation is, and what is the media clarity in this eye. It's very important to identify plus disease before you insert the speculum and start indentation, because it might mask and alter the plus disease. Look for the pupillary dilation, look for the vitreous haze. This photo shows the standard plus photograph, which is basically published, which shows how much dilation on tortuosity of the vessels. More than that, you should call as plus. If it's more than normal, but less than this photo, then you can call it pre-plus disease. Scleral indentation is a very important component of ROP examination, because these babies are awake, they are crying, and they are moving. The eye is not anesthetized, and you are under topical anesthesia. So the scleral indenter helps to stabilize the eye, rotate the eye, indent the periphery, and see the areas of interest. But it has to be a careful examination, otherwise you can end up with more damage to the conjunctiva. Then you need to identify the zone. We are all aware of the zone of ROP. Basically, zone 1 is the smallest zone of ROP, where the most severe disease comes in, and zone 3 will have the least severe of disease, and there's a high chance the disease will regress in zone 3. After you identify this plus, the zone, then you need to identify what stage of the disease is in. Stage 1 is basically a demarcation line. Stage 2 is a demarcation ridge. Stage 3 is extraretinal fibrovascular proliferation. Stage 4 is subtotal detachment, which can be 4A if it involves the macula, 4A without the macula involvement, 4B with the macula involvement, and stage 5, which is total retinal detachment. It's very important to record the data correctly, especially because a lot of medical issues are coming in, and you might refer the patient, there might be intraobserver variation. So it's very important to record the data correctly in the form. How to follow up? This will also covered in the further lectures. The early treatment ROP has given guidelines and divided ROP into type 1 and type 2 ROP. So type 1 ROP needs to be treated, which Dr. Dogra will soon discuss, and type 2 ROP is what needs to be followed up. So the follow-up will depend on the stage and the zone and where the child is at which stage. From 1 to 2 weeks the follow-up will be done. And you can end ROP screening when the retina becomes mature, that is when the vascularization has completed till 1 disc diameter of the temporal ora serrata. Then you can call the retina as mature, and a complete regression usually expected by 40 to 44 weeks of post-conceptional age. But the follow-up doesn't end here. You need to follow up these babies further on for development of amblyopia, for checking for refractive errors, checking for squint, etc. till the child is much bigger. Some typical challenges which we face is you have a non-dilating pupil. So you can see that sometimes you get these patients referred that ROP is not possible in an undilated pupil. So this is a problem, because if the pupil does not dilate today and if you have severe disease behind, the pupil will not dilate after 1 week. So you need to be aware that the pupil is not dilating. Possibly the dilating drops have not been put properly. So more effort should be taken to dilate the eye properly. Sit there, wait for half an hour, use the dilating drops again. Maybe the child just blinked and the eye drop just fell out. So if still it's not dilating, then you should be aware that this maybe you're dealing with a case of plus disease. Plus disease causes a rigid pupil and pupil does not dilate. There's an urgent need to look behind and see the posterior pole and look for plus disease, dilation and tortuosity of vessels. And once you find that the plus disease is there, then you need to be active and look whether you have a treatable case of ROP. Another problem which people encounter is the missing ridge. The ridge is not coming. The plus disease is getting worse, the dilation and tortuosity is getting worse, but no stage of ROP is coming. There's no demarcation line, there's no demarcation ridge. So where is the ridge? So this is a very common thing which we are encountering as more and more babies are getting saved and subject to poor neonatal practices. So what basically is happening here? So this is APROP, or aggressive posterior ROP, when you should have a high index of suspicion in all these cases. Typically, if you look behind, you open an eye, you see this kind of dilated tunica vasculosa lentis. You see there is a problem happening there. Now, tunica vasculosa lentis is a normal finding if you see a child preterm enough, but it gradually disappears as the child approaches term. So, but if you have a very angry-looking tunica vasculosa lentis, the pupil does not dilate, you should have a high index of APROP. This is typically how an APROP looks like. You see there's no demarcation line, there's no demarcation ridge, but you see the dilation and tortuosity of the vessels at the posterior pole is very angry looking. But there is no ridge here. There's no clear demarcation junction. And this featureless junction is what confuses people who keep on waiting for the ridge to appear, which is not going to come here. If you see on a closer look, you see all these loops are there, and if you see there are clear avascular areas inside it, the color here and the color here matches. So sometimes we find the fluorescein angiography serves to be a useful tool in many of these cases. Like you see this case, again APROP, it's very difficult for the person to realize where should he go and laser. There's no clear junction. Should he laser here? Should he laser here? Where is the loop? Difficult to see. So if you do fluorescein angiography, you will realize that everything just stands out. People keep on waiting for the ridge to appear here, but this is all just a false junction. Actually, the red line is where the actual junction is actually happening, and these are all avascular loops which are there, because this is as black you see, and this is also all black. So so the laser has to also be done between the blue and the red lines if you want this disease to go away. So many times people ask, is there an easier way to screen ROP? So there is the red cam. The red cam is a very expensive equipment, but it's very useful equipment for ROP and other diseases like retinoblastoma, FEVR, etc. And this is the RedCam 3, which is the latest model of the RedCam. The RedCam shuttle is a portable version of the RedCam, which you can easily, everything is replaced by a laptop and you can carry it along. And it's basically just you put a coupling medium and just put the camera over it, and it gives a very good 130-degree field photograph. And it's a mobile self-contained unit, easily used in the NICU, the OT, can be used by technicians, nurses, and you don't need the expertise which you need for indirect ophthalmoscopy indentation in preterm babies. And it's a useful teaching tool for residents, and now more and more it's becoming an important teaching tool for parents, because once they see what is happening in their eye, especially if the ROP is progressing, they are more attuned to your suggestions and consent, etc. And obviously Dr. Anand will discuss it further more, but it has been clearly validated that telemedicine has a very high role in treatment-warranted ROP with a high sensitivity and specificity, and RedCam is helping us to develop more and more telescreening programs across the world. And a lot of these mobile apps are also coming in, where the experts just screen in the periphery, the images transferred over the internet, and they just come across the mobile app and they can give their opinion for treatment or follow-up, etc. So I'd just like to conclude by saying that the screening program is the only way to detect ROP. You just cannot hold it as a one-off basis that screen one child once in a while. If you have a nursery in your hospital and you cover it, then you have to have a screening program if you want to detect all these babies, because there is no other way to catch all these babies in a screening besides the screening program. The most important problem in our country is a lack of awareness in pediatricians, ophthalmologists, obstetricians, parents, which leads to development of advanced stages of ROP, which come to these tertiary centers. And by the time they are blind, and this will eventually lead to a lot of medical legal cases, because there are clear-cut guidelines, national as well as international, for screening ROP, for treating ROP. And in large number of cases, the ROP regresses spontaneously. In many cases, it regresses by treatment very effectively. And so this awareness has to be there if you want these children to see. And of course, we have to be aware of APROP. A lot of experienced users also get tricked by APROP, and newcomers obviously get absolutely confused by APROP. They need to be aware of what is APROP and have a high index of suspicion in these cases. You have to have the right training to do it. And in the end, of course, proper training is very essential. You just cannot, just jump into ROP screening. You have to have a proper training, and otherwise you'll have a cartload of medical legal cases following you soon. Thank you so much.